So someone pointed out that I didn't have a lot of surgery content on my channel. So I decided to record you guys a very quick video. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at anal fistula. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. So before we actually dive into talking about anal fistulas, let's cover a little bit about the anal anatomy. So remember that the rectum is about 15 centimeters long and is going to be extending from the rectal sigmoid area to the anal rectal line. It's going to be curved with the sacrum and contains 3 folds. The rectal wall is going to be consisting of layers, just like the rest of the GIT. It's going to be consisting of a mucosa, a submucosa, and 2 complete muscle layers, an inner circular muscle and an outer longitudinal muscle. Remember also that the anal canal is about 3.5 centimeters long and is going to be extending from the anal rectal line to the anus. We'll be focusing mostly on the anal canal because most of these pathologies are going to be arising in the anal canal. You also have a special line that's known as the dentate line, or you can refer to this as the pectineal line. This is what's actually going to be dividing the anal canal into an upper part, which is going to be consisting of this columnar epithelium and an autonomic innervation. This is very important to remember because of the different types of pain that can arise when someone has anal pathologies. This region is going to be derived from the endoderm, and the dentate line also separates the anal canal into a lower part, which is going to be consisting of the squamous epithelium that's going to be continuous with the perianal skin. This is going to be innervated by the pudendal-somatic nerve. So it's going to have a somatic type of innervation and is going to be coming from the ectoderm. This is very important to remember because pain that is coming from above the dentate line is going to be visceral in nature, meaning that it's going to be diffuse, it's going to be poorly localized, while the pain that's coming below this line is going to be somatic, it's going to be sharp, it's going to be well localized. Remember that the columns of Mogagni are going to be beginning at this line and they're going to be extending upwards. Here is a picture of what I've been talking about. So here you have the rectum, as here you have the lines of the anal verge or the dentate line, and then of course this is the transitional zone. Above this is going to be innervated by this autonomic nervous system. Below this is going to be innervated by the somatic system. So above you're going to be getting this visceral pain, below you're going to be getting somatic pain. And then you'll have 2 sphincters that are going to be lining the anal canal. An internal sphincter, which is under the control of the autonomic nervous system, and an external sphincter, which is under voluntary control. So remember that within the anal canal, you have 2 anal sphincters. You have the internal sphincter, which is going to be the circular muscle that's going to be lining the inner surface, and it's going to be smooth muscle that's under the control of the parasympathetic nervous system. So it's under involuntary control. Then you also have the external sphincter that blends with the outer skeletal muscle, and it's going to be continuous in 3 parts. It's going to be having a subcutaneous part, a superficial part, and a deep part. It's under voluntary control, and it's under the control of the pudendal nerve, which is S4. Remember also that the superior border of the external sphincter is going to be fused with the puborectalis, which forms kind of like a sling that's going to be originating at the pubis and is going to be joining the rectum. This is also another mechanism that's going to be helping in the control of the internal materials on the inside. Remember that the space between the sphincters, the internal and external sphincter, is referred to as the intersphincteric space. This is very important because it's going to be consisting of this fibrous continuation of the longitudinal smooth muscles of the rectum, and it's going to have certain glands. It normally has about 6 to 10 anal glands in this space, and these glands are going to be discharging their contents into the anal crypts of the dentate line. Infections are going to be originating in these glands, and this can actually be the primary cause of the perirectal abscesses as well as the fistula in anal or the anal fistulas. Let's talk now about fistulas. Remember that a fistula is just an abnormal connection between 2 epithelial or endothelial line surfaces surrounded by granulation tissue. And fistula in anal or in anal fistula is going to be this chronic abnormal connection that's going to be lined by some degree of granulation tissue, which runs outwards towards the anorectal lumen, that's the internal opening, to the external opening of the skin of the perineum or the buttock. Or sometimes, rarely in women, it can actually extend to the vagina. Remember that an anal fistula is going to be having its external opening in the perirectal skin and its internal opening in the anal canal at the dentate line. The anal fistula may be associated with certain conditions like Crohn's disease, tuberculosis, lymphogranuloma venereum, actinomycosis, HIV and AIDS, rectal duplication, foreign bodies, and sometimes malignancies. There are some non-specific anal fistulae, and they are much more common in men than they are in women. And remember that these individuals that develop these anal fistulas are going to see them in their third, fourth, and fifth decades of life. So, remember that pain is rare with the anal fistulas, and often the patients are going to be complaining of this perirectal itching, this irritation, and this discharge that's going to be there. It is believed that the fistula in anal can either be due to the arising from the glands. We call this as cryptoglandular in 90% of the cases, and it's going to be associated with infection of the intersphincteric glands, like is depicted on the right of your screen here, where you have these anal glands. This is common in 90% of the patients. You may also have a non-cryptoglandular type of anal fistula, which is going to be seen in 10% of the cases. Causes of anal fistulas include drainage in 40% or rupture of an anorectal abscess. That's an infection of the anal gland. This is the most common cause. And remember that the anal fistula is going to be forming during the chronic stage of acute inflammatory process that begins in the intersphincteric anal glands. This can eventually extend and result in a supralevator, an ischiorectal or perianal abscess. Remember also that with this chronic inflammation, the abscess communicates with the external surface, forming a supralevator, a transsphincteric, or sometimes an intersphincteric fistula. It may also be due to Crohn's disease. You may have other things like diverticulus or diverticulitis with perforation and fistula of the perineum. You may have infections such as TB, HIV, actinomycosis, lymphogranuloma, venereum. You may have malignancies of the distal rectum or the anal canal or the perianal skin. It may be due to trauma with foreign bodies, iatrogenic causes, and even some anal fissures. You may sometimes have hidradenitis suppurativa. Now, how do we classify these type of fistulas? I want us to remember one important classification in terms of management. So you can divide them into as low-level fistulas, which are those that are opening into the anal canal above the internal ring. Then you have the high fistulas. These are the ones that are opening into the anal canal. Actually, the low levels are below the internal ring. Then the high levels are the ones that are opening at or above the internal ring. Remember that you also have a standard classification, which was first postulated by Milligan Morgan and Gallagher, and it's divided into 5 main types of fistula. You have a pelvirectal fistula, which is what is depicted on 1, appearing in this area. You have a submucous fistula, which is appearing here at 2. You have a subcutaneous fistula, which is appearing at 3. You have a high-level anal fistula, and you have a low-level fistula. Remember that the subcutaneous type is the most common, and the low anal type is the one that is also quite common. Then you also have a PAC classification, which is in relation to the sphincter. You can have an intersphincteric fistula, which is traversing across the fistula. These ones are accounting for 70% of the cases. You may have a transsphincteric fistula, which is accounting for 25% of the cases. You may have a supralevator, which is above the sphincters, which is accounting for 4% of the cases. And you have an extrasphincteric fistula, which is not really outside the sphincters and accounting for about 1%. Clinical features include persistent symptoms or non-healing, following abscess drainage, a discharge that may be continuous or intermittent, and you may have history of soiling. You may have pruritus, which is this intense itching in the anal area. You may have rectal pain, which may worsen on sitting and defecation. You may have, if it's untreated, it may lead to sepsis and anatomical changes that may lead to things like incontinence. Remember that when you examine these patients, there is something that's known as Goodsall's rule. And I want you guys to actually pause and understand this very well. So suppose the patient is lying in anatomical position. So let's say this is the anterior bit, this is the posterior bit, this is the anus of the patient, and you divide the anus in half in this frontal plane. So if you have a fistula that's having an opening above this line, it's most likely that the tract of this fistula follows a very straight pathway. Whereas if it's opening behind this posterior aspect, it's most likely following a curved pathway. But of course, there is some exception to this. If you have an anterior fistula that is about more than 3 centimeters from the anus, then it's most likely going to be following a curved pathway, just like the anterior type of fistula. So that's what the Goodsell's rule is all about. So it's just in relation to the location of the internal and external openings of the fistula and anal. Remember that a fistula that is occurring posterior to this line that is drawn in the frontal plane bisecting the anus, it's going to be following a curved pathway. One that's drawn anterior to this or has an opening anterior to this is going to be following a straight pathway. The exception is sometimes you may get these anterior fistulas that are more than 3 centimeters from the anus. These ones are going to be following a curved pathway, just like the posterior type. Sometimes you may need examination under anesthesia because there may be some significant discomfort. Remember that a perectal examination shows an indurated internal opening that's usually in the midline posteriorly. Remember that most fistulae are going to be in the posterior half of the anus. Investigations to order include a simple, for simple fistulas are not really necessary because they are diagnosed clinically, but you may order some investigations like a chest x-ray, ASR, and a barium enema to determine the cause. You may also order fistulogram if it's required. It's going to be done under anesthesia. You may order an MRI or an MRI fistulogram, which is ideal. You may also get an endorectal ultrasound or an ultrasound of the perineum. This is useful to assess the deeper planed type of fistulae. Then you may get a discharge study, you may get methylene blue study, and you may sometimes want to get a biopsy. A colonoscopy, often when ulcerative colitis or Crohn's disease is actually suspected, can be gotten. Here's a picture of a fistulogram and an x-ray showing a tract. Now, how do you manage these cases? Remember, I told you to keep in mind the two main types, the low fistula and the high fistula tract. So the mainstay management is, of course, to lay the fistula open, and the procedure depends on the type of fistula you have. For the low tract fistula, predominantly the superficial, the intersphincteric, the low transsphincteric, you may do a fistulotomy in which the fistula is open and is left open and it heals by secondary intention. Sometimes you may inject some fibrin glue or sealant, and sometimes an intersphincterotomy is the treatment of choice for an intersphincteric fistula. You open into the sphincter. Of course, there may be some risk of having some fecal incontinence. And of course, with the high fistula tract, you may perform a fistulotomy and place a ceton cord, which is left in the fistula to allow it to drain during the healing process. And in the first stage of the operation, a ceton suture is going to be placed around the sphincter to stimulate fibrosis adjacent to the sphincter. And in the second stage, which is performed roughly about 6 to 8 weeks later, the intersphincteric portion of the fistula is going to be laid open, and this is to prevent incontinence. Some advancement flaps can be done to adjust the mucosa and can be used to seal the internal opening. You may sometimes have some fistula plugs and some ligation of the intersphincteric fistula tract. I really hope you enjoyed this video on anal fistulas. If you did, consider subscribing to the channel. Hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.